Hello everyone. The next topic in line is ectopic pregnancy. Before going on to the details of this topic, let me tell you this is Pmdc is one of the most favorite topic which falls under step 2 examinations. Now what they want you to learn is how to make diagnosis and how to manage a case with ectopic pregnancy. They always come up with different case scenarios. For example, a 22-year-old female presented with severe pain in right iliac fossa and she complains of mild PV bleed. Examination reveals tenderness in right iliac fossa and she is hypotensive. Her last menstrual period was 6 weeks ago, which means she is having a gestational amenorrhea. Okay, now how will you make a diagnosis of ectopic pregnancy? Recall the lecture PV bleed, remember the flow chart, how to approach a patient with PV bleed. First, look at the presentation, which describes as less than 24 weeks of gestation. So either it could be abortion, ectopic pregnancy, gestational trophoblastic diseases, because only these are the three differential diagnoses which should come up in your mind as she is presenting within 24 weeks of gestation. Young age, 22 years old, severe pain in right iliac fossa plus pervaginal bleed. It represents that this is the case of ectopic pregnancy until proven otherwise. Now let's move on to the other slide and understand what is ectopic pregnancy. Okay, normally the fertilization takes place in fallopian tube, and after fertilization the fertilized ovum moves into the uterus and implants in the uterine cavity. Now if the implantations occurs anywhere else outside the uterine cavity, then it's termed as ectopic pregnancy. So let's read. Implantation of fertilized ovum outside the uterine cavity. 97% occurs in fallopian tube. This is the most common site of ectopic pregnancy. It's fallopian tube. The 1% it could be possible in ovaries, uterus, in ligaments of the uterus, peritoneum, fold, cervix, and vagina. Now there are various pathologies which impairs the movement of fertilized ovum from fallopian tube to the uterine cavity, which might include pelvic inflammatory diseases secondary to the bacterial infections, which leads to the development of strictures. Tubal surgeries and tubal reconstructions are the most common or most strongest risk factor for ectopic pregnancy. What happens that it is possible that the female previously have a history of abortion or she have a history of ectopic pregnancy and her fallopian tube get ruptured and she had been gone through salpingectomy. It means that you open the fallopian tube, you took the ectopic mass and then you reconstruct it in order to let her to conceive again in the future. ART, assistant reproductive techniques. This one is interesting. This is basically the test tube babies, which might include the GIFT and the ZIFT. GIFT stands for gamete intrafallopian transplant, and Asherman syndrome. Asherman syndrome results because of the complication of D and C method, which is also termed as dilatation and curettage method. Female has a history of past history of abortions, and the likely chance of Asherman syndrome increases. Basically what happens is instead of using the blunt curette, the gynecologist may uses the sharp one, and it leads to the formation of adhesions within the endometrium. So endometrium becomes sticky. That's what Asherman syndrome is. Let's move on to the next slide, the pathogenesis. In order to understand the pathogenesis, let's have a look at the picture. Okay, this is fallopian tube. The fertilization takes place in fallopian tube and then the fertilized ovum moves from fallopian tube to the uterine cavity. Now what happens is that when the fertilized ovum is not able to move from fallopian tube to the uterine cavity, this fertilized ovum start invading or it implants within the fallopian tube. Now as the time increases, the size of the sac will increase, and eventually as the sac size will increase, it will lead to the rupture of this fallopian tube, and when it leads to the rupture fallopian tube, it will lead to the massive intraperitoneal bleed. Let's give a read. When fertilized ovum remains in fallopian tube, it starts invading the tube and eventually the tube gets ruptured, thus results into massive intraperitoneal bleed. Now, what will be the clinical features? She will present with gestational amenorrhea, there will be abdominal pain and plus PV bleed. Abdominal pain will be sudden severe at fallopian tube, which will be colicky in nature. General physical examination, if the patient comes to you and she is in unstable condition, then it means that she is already in shock. The signs and symptoms will be decreased BP, increased pulse, and cold and clammy skin. All the signs and symptoms of shock. Tenderness and hardening over the abdomen, and Schindler sign will be positive. When you do the PV examination and you move the cervix, the pain will be move or increases towards the site of ectopic pregnancy. That means the Schindler sign is positive. Now, this is very important. Often it's asked in Pmdc that what will be the initial investigation of choice for ectopic pregnancy. So it should be beta HCG levels. Initially, you will check the beta HCG levels to confirm the pregnancy, whether it is ectopic or it's normal. Then secondly, it's abdomen ultrasonography. It will reveal no gestational sac in the uterine cavity. Why? Because it's already present somewhere else, not in the uterine cavity. It could be in fallopian tube, it could be elsewhere where the 1% chances of being ectopic. This is very important. RCOG's guidelines, it stands for Royal College of Obstetrics and Gynecology. Okay. It means, what does RCOG's guidelines represents? RCOG's guidelines states that the diagnosis should be based on two of these investigations. One should be beta HCG level and second should be radiology. Among radiology, you can either go for abdominal ultrasonography and transvaginal ultrasonography. Now, these guidelines will guide you that whether you have to go for transvaginal ultrasonography or abdominal on the basis of beta HCG levels. If the beta HCG levels are more than 6,000 international unit, then go for ultrasonography of abdomen. If it's less than 6,000 international unit, then go for transvaginal ultrasonography. And what you are going to look for gestational sac. Obviously, there will be no sac because the sac is in the fallopian tube. Likely chances because 97% that's the common site. Now, RCOG's guidelines are also very important while in the treatment options. Now, what does it say? It says on the basis of this beta HCG levels, on the basis of patient are symptomatic or asymptomatic, whether the patient is presenting as a stable or the unstable patients, what will be the treatment protocols. Every time the treatment protocols will be different. Let's study via a picture. Okay, management of ectopic pregnancy. This is very important. Whether the patient is unstable or whether the patient comes to you unstable. Okay, if the patient is unstable, it means patient is already in shock condition. You will resuscitate the patient, and after you will resuscitate and you will maintain the vitals, soon after you will go for the urgent laparotomy. If the patient is stable, the scenario will be different, the treatment protocols will be different. You have to check the beta HCG levels. If the beta HCG level is more than 3000 and gestational sac size is more than 3.5 centimeter, then you have got two options. Okay, these two options could be you can do a laparoscopy and remove the ectopic pregnancy. Before, you need to check the beta HCG levels. If one fallopian tube is normal, then remove the ectopic pregnancy in the other fallopian tube. Then you need to remove the whole tube. If the fallopian tube is diseased, one is diseased and one have got the ectopic pregnancy, so the treatment option will be salpingectomy. It means you will open up the tube, you will remove the ectopic mass and you will reconstruct it. Why would you go for salpingectomy if the one is normal and the other is having the ectopic pregnancy? So why don't you just go for salpingectomy? You will be able to save the fallopian tube. But no. Why? Because we are already read in the etiologies that tubal surgeries and tubal reconstructions are the most strongest risk factor for ectopic pregnancy. So that's why you have to go for salpingectomy. Okay. Now, if the beta HCG level is less than 3000, then you have to go for the conservative treatment, and we'll inject the methotrexate injection 50 milligram via laparoscopy within the fallopian tube, and then we'll follow up the patient, the dose increase on the basis if the beta HCG levels comes down. Now, if the patient is asymptomatic, beta HCG levels is less than 1000 international unit. Now what will you do? You have to go for the expectorant treatment. What does it mean? It means that you have to do nothing. You just need to follow up the beta HCG level twice a week, and it is possible that the beta HCG level will decrease within 7 days. Why? What does it mean? It's because basically body itself will destroy the ectopic mass. Why? How? Via apoptosis. So here you don't need to intervene the patient because the body itself will get rid of ectopic mass. Now let's study a case. A 29-year-old woman with a medical history of chlamydia presents with left lower quadrant abdominal pain for the past 8 hours. 29-year-old young female, risk factor is also present. Pain is also there in the left lower quadrant. And she also stated that she has some abnormal vaginal bleeding. Abnormal vaginal bleeding is also there. Her last menstrual period was 6 weeks ago. On physical exam, blah, 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 blah. Which of the following is the most likely diagnosis? Ectopic pregnancy, menstrual cramps, diverticulitis, ovarian torsion, ovarian cyst. Okay, let's exclude these options one by one. Ovarian torsion and ovarian cysts are not the possibly likely the diagnosis. Why? Because ovarian torsion and cysts, they never presents with vaginal bleeding. Diverticulitis, no, because it also presents with rectal bleeding instead of vaginal bleeding. Menstrual cramps, no, because they are not associated with an altered menstrual pattern. So the only option we left is with ectopic pregnancy. So let me tell you, this is very important. From exam point of view, questions might be asked under what circumstances you will go for salpingectomy and under what circumstances you will go for salpingectomy. What else is important? RCOGs guidelines, कोई रात को भी जगह के पूछो तो आना चाहिए. And I think that's all. Thank you.